as means of introduction, scoliosis is just a curvature of the spine, and about 1 to 3% of the adolescent population will have scoliosis. Our neuromuscular patients, cerebral palsy, spina bifida, et cetera, it's much higher. And this is major elective surgery. The average blood loss could be about 450 cc's, roughly about 45 cc's per spinal level fused. But for our neuromuscular patients, it could be even more dramatic, up to 70 or 80% of their blood volume. So trying to be innovative and creative at ways to preserve blood is very important in these patients. Sorry, guys. There we go. So when we talk about transfusions, there's kind of two situations we find ourselves in. We don't want to unnecessarily transfuse patients, either because we don't want to. So you've heard about all the complications, and you're very familiar with the complications of transfusions, including surgical site infections. But also in our Jehovah's Witness population, we can't give blood. They will not accept transfusion. So in our day-to-day standard surgical approach, we really strive not to require transfusion for these surgeries. And in fact, it has become increasingly rare for a idiopathic scoliosis patient to need a transfusion. But for our Jehovah's Witness patients, it's not an option. So what is our approach to blood conservation? Well, it starts in the preoperative period. And we'll go through this, but we want to maximize the patient. We want to discuss intraoperative options, tools, techniques to limit bleeding and help with clotting. We want to involve the appropriate colleagues. If you look at that little circle graph on the right, certainly the patient is in the center of the wheel. The surgeon is just one spoke. And there are a tremendous number of other folks who need to be participatory to give the best outcome for this patient. You know, Kevin and I work with our hematology contacts, or blood bank consultants, or anesthesiologists, et cetera, all centered on the patient in order to minimize the requirements for blood in this group. And then finally, we ask ourselves, are there other surgical options? There's always more than one way to fix a problem, or more than one surgery that could be helpful. We try to balance the pros and cons of each approach. So when we talk about maximizing the patient, you've heard in far greater detail than I will provide this information this morning. But just for my orthopedist perspective, we first look to see whether they have anemia. We look for medications or supplements they could be taking that can cause bleeding. So anti-inflammatory medications, fixed fish oil, garlic, or anticoagulants. We also look for any evidence of underlying disease. Our neuromuscular patients on many levels have a higher risk. Their clotting mechanisms are not as highly developed, and their surgeries are much more invasive. And so we know that we're going to have the potential for significant bleeding, but also kidney or GI disease can cause problems with clotting. So we do a lab evaluation, so they all get the standard blood count, but also iron studies, reticulocyte counts, B12 and folate levels, and coags. So what we've seen is not rarely even, patients will have no history of bleeding, no easy bruisability or bleeding gums when they brush their teeth or things like that, and may even have had surgery. But we've diagnosed several patients with von Willebrand's disease, which was previously not known. So we really try to go through this whole process to make sure there's not a subtle bleeding disorder. Spine surgery is very invasive, and their life up to that point may not have provided enough trauma that it brought this bleeding disorder to light. So making sure we kind of go through this whole process before the surgery is important. Okay. So the next step is we want to maximize the hemoglobin. So again, lab values are very important. You've heard a lot about this morning, so I won't belabor the point. But if they have a low ferritin or transferrin saturation, iron infusion, as you've just heard, can be extremely helpful. We use the Ganzoni formula, but there are others to determine the amount of iron you're going to give. And if we have at least 4 or 5 weeks, which we usually do for these surgeries, we can really optimize their hemoglobin levels. So the next possible option is, do we want to use erythropoietin? And for a standard idiopathic scoliosis patient, I would not do this. But for a Jehovah's Witness patient, we often consider this as a means to really maximize the hemoglobin. We aim for something in the high normal range. One of the things that we do intraoperatively that I'll talk about is we use tranexamic acid, and that is in combination with increased hemoglobin, potential risk factor for thrombotic events. So we have to balance all of these things as we try to come up with the best strategy for each individual patient. So the nutritional status is important. You've heard about this as well today. I'm not going to belabor this, but you're making sure their vitamin B and the folate levels are normal. But the other thing that we think about is anything that we can do nutritionally to lower the risk of infection. When you look at someone who's had a spinal fusion and they have an infection that requires a surgery for debridement and cleaning, the bleeding from the cleaning surgery, the debridement surgery, is often substantially more than the bleeding from the original surgery. And since their hemoglobin is going to be lower and their iron stores are going to be a little depleted from the bleeding they have from the original surgery, an infection can really push this over the edge. So on many levels, it's important to prevent infection, but particularly on these patients where we really want to avoid blood products, be more helpful. And then we try to address, obviously, there are other medical issues. If they have a chronic inflammatory disease or kidney disease, making sure those are maximized and dealing with the anemia that results. So when we have the discussion with the parents, most importantly, we do a risk assessment. And there are multiple papers that have been done and looking at risk factors for transfusion requirements during adolescent spine surgery. And in general, patients with many levels that need to be fused, so longer fusions, neuromuscular scoliosis, again, we've talked about that. It's a much larger surgery. Patients who need what are called osteotomies, and I'll talk about that in a minute. I'll show you what that is. All of those patients have a higher risk of bleeding. So if we know that ahead of time, we can stratify their risk. So we want to look to improve their intraoperative coagulation, but we also want to look at techniques to minimize bleeding. And again, we want to decrease their infection risk. So there are several factors that are important, right? So if we look at intraoperative options, there are several factors that are addressed by our anesthesia colleagues. Temperature control is very important, trying to avoid hypothermia, both for infection purposes and for coagulative purposes, very important. We maintain hypotensive anesthesia. The spinal cord can suffer injury if it's not well perfused, but keeping the blood pressure at a lower level, we usually shoot for a mean arterial pressure of 50 to 65, is very helpful in minimizing the ongoing bleeding from the muscles. Hemodilution is another technique that was popular years ago. Blood is taken off and replaced either with a 3-to-1 ratio with crystalloid or 1-to-1 to colloid. And the concept is that you are bleeding more dilute blood, and then those cells are then transfused back to the patient. And some of our Jehovah's Witness patients will actually allow that as long as the circuit is kept closed. There are some potential side effects. Blindness in prone surgery has received a lot of kind of press recently. Very, very rare in children, but the thought is that that may be a factor. So we don't really do that as much anymore. Epidural anesthesia with the venodilation also keeps the mean arterial pressure low and prevents ongoing bleeding. Rector spinae blocks will use a lidocaine with epinephrine, and that can actually control bleeding somewhat. We do use TXA very frequently, and there's really no agreed upon dosing regimen in the literature. They're talking with colleagues at other institutions. It's all across the board. So usually we'll use a bolus dose of either 10 or 20 milligrams per kilogram, and then a continuous drip. And that really helps minimize ongoing bleeding. There are some concerns, again, of thrombotic events. We've seen that in our hospital, rarely in adults. We've never seen this in children, but it's something that we try to be aware of. Apologize, Guy. And then finally, DDAVP for our patients with von Willebrand's disease can be helpful. So moving on. So some other intraoperative options. So self-salvage. This is a very helpful technique. We use this in all of our scoliosis patients, and it is tolerated by Jehovah's Witness patients who require a closed circuit between the body and the transfusion that's coming back. And essentially, we will suction any ongoing losses. It gets washed by the machine and it's given back to the patient. So you basically have a unit of blood with a high hematocrit. And my experience is about 1/3 of our losses can actually be returned to the patient. So that could be a very helpful technique. And finally, surgical technique is important. There are several options that we have available to us to help with bleeding. So spray-on collagen thrombin products are helpful. Fibrin sealant is helpful. So one of the things we do with spine surgery is we put screws into the bones, and the bones can bleed substantially. And if we do 20 screws and you're losing 10 cc's per screw, that winds up being a substantial blood loss. So we have injectable fibrin sealants that actually plug the holes where the screws go in, and that's been tremendously valuable to us. The U.S. military developed kaolin soaked sponges, and packing a wound with those can be helpful. And the aquamantis has also revolutionized our blood management. So this, instead of using electric cautery, if you look at the two prong tips here, heated water basically is jetted between them, and it's a bipolar sealant. So it actually is causing thermal damage to the collagen fibers in the vessel, so they shrink and permanently seal. And it's less pinpoint maybe than the electric cautery we use. So for massive bleeding, particularly with our neuromuscular patients, you can easily control the bleeding with minimal tissue damage. So that's been a game changer. So, so when we look at our strategies, there are surgical technique strategies that we can do to limit bleeding. So one thing that I always do in our Jehovah's Witness patients or our large neuromuscular patients is we make sure we have a skilled assistant. This is not the case to teach a junior resident how to do the surgery. I'll do this with a junior partner or a fellow, and that's enormously helpful at very kind of effectively exposing the spine and minimizing the bleeding. And that's where most of the bleeding comes from. Neuromonitoring is important for spine surgery. And we need a skilled neuromonitoring technician. If they are uncomfortable with our spinal cord signals and they feel that there could be something going on, the first move usually is to raise the blood pressure, which increases bleeding. So trying to make sure the team all understands our priorities and is very comfortable in a hypotensive environment is key. Something else I find very helpful for our large cases, for our neuromuscular cases, is I will expose the lumbar spine and put all of my instrumentation, my screws, into lumbar spine, and I will pack it to minimize bleeding. And then I will open the top of the spine and do that rather than opening a huge incision and allowing this ongoing bleeding to occur. So different ways of exposing or approaching the patient can be helpful to minimize bleeding. And then finally, for our Jehovah's Witness patients, particularly, frequent checkpoints with potential to abandon the procedure have to be done. So as we do our exposure, we look at the end of that and what our blood loss has been. We look at the H&H. Spectrophotometry can be very helpful for kind of a continuous monitoring. But essentially, you're trying to find your stopping points, and those are helpful to identify ahead of time, where you'd say, well, if we've lost a lot of blood up to this point, it probably is not a good idea to continue, and we should stop, and then we can complete this as a second stage. So knowing that and deciding that ahead of time is very important. So large curves that are stiff often increase blood loss, and there are several ways to handle that. So this is the osteotomies I mentioned earlier. If you look at your spine, we basically take out the joints and the ligaments between the bones, and that will substantially loosen things. This is what it looks like. From the back, you have your joints here, and we actually remove bone here. So the combination of cutting the bone and epidural veins can lead to a fair amount of bleeding. So this is a very helpful technique, but we have other strategies that we sometimes use. So one thing that I found to be very helpful is preoperative traction. And we can use that both before surgery, during surgery, and there's some other techniques that I'll talk as well. Secondly, we don't have to shoot for perfect. If you look at this patient, this is a 148-degree curve in a patient with severe dystonia. This is a horrible deformity, and we didn't have to get this down to zero. The X-ray on the right is his intraoperative X-ray. With a limited number of implants and some intraoperative traction, we're able to obtain a nice balanced spine and really limit the amount of struggle, and by struggle, limit the amount of bleeding during the case. Other times, the case is so monumental, we do it in a staged fashion. Right, so this is traction. We have a custom wheelchair and walker apparatus. We make them in different sizes for different height kids. This is from a paper that we had written a few years ago. And essentially, we gradually increase the weight so that the deformity is slowly stretched out over time. This allows a much more simplified procedure and often eliminates the need to do osteotomies. And this is intraoperative traction. Can't really see because she's got a lot of hair. She has her halo ring on here connected to the top of the table with weight, and we use skin tape in this case to have some weight on the bottom of the table. And by just doing our exposure and working with the patient in traction, hour after hour, we've noticed that we get slow, gradual correction. And again, we can eliminate the need to do a lot of our osteotomy work. Temporary internal distractions, another little trick. And I put this picture in for two reasons. One, I think you can get a sense from looking at this how massive the exposure is for a spine surgery. And this is all muscle, which all bleeds. So you can kind of see what some of our problem is. But basically, you have this big curve, and we put two short temporary rods in with it connected to another rod. And every few minutes, we just keep stretching. So we'll get a gradual correction. And then we'll put our final rod in. and this is what it looks like in a child with cerebral palsy. You'll have a screw or a hook in the pelvis. So you can't really see under this muscle. We have some hooks on the ribs, and slowly spreading these rods apart until we get what we need. And we drop our permanent rods in on that side, we put a rod on the other side. And we've been able to do this by minimizing the amount of osteotomies and by quickly getting the correction that we need. So sometimes we do this as a stage procedure, and this could be a planned or unplanned, as we mentioned before. The nice thing about staging, we can use erythropoietin, iron, and nutritional management between the stages to really get the patient optimized. We can also do traction between the stages. And so the key thing that has to happen really with the patient, surgeon, and the family is a discussion of the goals. What are we really trying to accomplish? Is this a curve that we need to make perfectly straight? Are there other ways to do it? What are the risks and benefits of being more or less surgically aggressive? And what is our tolerance for a staged procedure? And by factoring all of those things into an individualized plan, we can do what's right for the patient. So what's the protocol at our institution? So we identify a high-risk patient. And for all of our scoliosis patients, we use TXA, we use Cell Saver, we use the Aqua Mantis, and we use some other techniques. But for our high-risk patients, either medically high risk, like a neuromuscular patient or Jehovah's Witness patient, we liberally involve our transfusion-free medicine service. And this is where Kevin and I have worked together. Our hematologists are really a crucial part of the team. We have a complex perioperative program for our anesthesia department. And we get other consultants as needed, nutrition, pulmonary, GI, et cetera. The goal here is identifying every need of the patient and meeting them beforehand, because remember, this is elective surgery. When we schedule these surgeries, they're scheduled with a skilled assistant, as I mentioned, but also part of our high-risk anesthesia team. All of our anesthesiologists are very good, but some excel in different areas, and there's a core group who are excellent in managing these patients intraoperatively. Once we've done that, we have our discussion with the family. Occasionally, we involve their clergy, particularly in the case of Jehovah's Witness patient, or the transfusion-free medical service, and we really lay out what our goals are for the procedure. Occasionally, there could be a surgery, and we've had cases where there clearly would be such a dramatic. I had a patient with scoliosis who had an enormous hemangioma in all of their paraspinal muscles, and there was absolutely zero way to safely operate on this child without catastrophic blood loss, and they would not survive without a transfusion. So having those conversations beforehand and knowing when to say no is very important. But what we found in rare cases that occurs, in most cases, we can work with the family and their own individual beliefs and come up with a plan that makes everyone satisfied and makes us feel that we're going to do the right thing for the patient. So this is a case example. So this is a 13-year-old girl who was sent to me for scoliosis. She had seen a previous surgeon, but didn't follow up, and mom works for a neurosurgeon who thought she should see somebody. She's otherwise healthy, but the family, they are Jehovah's Witness family, so transfusion is off the table completely. So we got Kevin involved, hematology involved, and we had a family discussion about what their specific beliefs were. So no blood products, but Cell Saver was okay, erythropoietin, tranexamic acid, and iron were all okay. And we also discussed this was not a horrible curve, but we talked about staging options or possible traction. So her blood work was not terrible. She was a hemoglobin in the low normal range. Platelets were normal. She also had sickle cell trait with no known history of any issues. Her ferritin and iron were kind of low normal. Saturation was 18%. Iron binding was right in the middle, and her folate was also low normal. So with all that information, with the assistance of our hematology colleagues, we received IV iron over multiple doses and folate, and 10,000 units of EPO IV. Her pre-op hemoglobin at that point was raised to 13.2. So we had discussion with our blood bank and hematology and anesthesia colleagues about the potential risks of Cell Saver leading to sickling with sickle cell trait. And it was felt that the risk was very low, and there's good support in the literature for using Cell Saver in these patients, so that was good. And then we talked with anesthesia, hematology about assessing the patient's thrombosis risk and customizing the dose of tranexamic acid to avoid thrombotic events. The family. All right, so a surgical plan. So we discussed preoperative traction. We discussed the different checkpoints. And this is important for us. We discussed really not so much in a legal sense, the Rhode Island law, but it's always important. And with all of my patients, we explain that, while we have to respect their beliefs, they have to kind of respect ours in a similar sense. And, in cases of life-threatening immediate hemorrhage in the operating room, a transfusion would be a possibility. Most patients understand that. But we also clarify that in the postoperative period, we would have to use other tools and techniques to raise the hemoglobin. So we just try to get a sense. This patient is under 14, so technically, we can make decisions for. In Rhode Island, children over 14, if they are allowed to tell you that they don't want blood, and you have to respect that just as if they were an adult. So probably understanding what that is in your state is very important. So this family chose traction. Again, the feeling was it would be an easier, quicker correction, fewer implants. We had a second attending surgeon involved, an experienced anesthesia neuromonitoring team. She underwent a spinal fusion from T2 to L3. So we do some math beforehand. So the total blood volume was roughly 4,150 cc's. And so our blood loss was 300 cc's, which is about 7% of her blood volume. And so we kind of play around with a bunch of different formulas to predict how much blood is too much. There's the maximum allowable blood loss before transfusion, and you can look at what the child's blood volume is, their starting hematocrit, what your minimum accepted hematocrit is. So if we plug some numbers in there and say, boy, I wouldn't want her to be much lower than 21, even though I wouldn't transfuse any patient for a hemoglobin of 21. In a Jehovah's Witness patient, that would be a stopping point. So that's a fairly significant blood loss. The other way we look at things is 20% of blood volume is responsible for clinical shock. So if we get to that point, that's about 800 cc's. So keeping the blood loss at 300 cc's, made this a very reasonable surgery. I use intrathecal morphine for pain management postoperatively. This also keeps the blood pressure at a reasonable level postoperatively. If you think back to that clinical photo with all those muscle edges exposed, there is the potential for significant ongoing bleeding. And so trying to minimize that is very important as well. So in summary, blood conservation is a team sport and communication is key. With these patients, we have to plan ahead, be flexible, and we have to assemble a great supporting crew.